Joining us to better understand this condition and its management is a consultant pediatrician, Dr. Ikechukwu Okongu, with University of Nigeria Teaching Hospital in Enugu. He joins us virtually. Hello, doctor. Good to have you join us today.
Good to be here, Petra. How are you doing?
Very well. And you?
Thank you.
All right. So we're looking at ADHD. Talk to us. What is that?
So ADHD, full meaning attention deficit hyperactive disorder, or hyperactivity disorder rather. I won't say it's a very common illness. I'm sure maybe many viewers might be hearing about it for the first time. It's not like the usual malaria that we hear about. But basically, it's that you have a child. It's a psycho problem, and it means that you have a child who attention deficit has attention deficit in this. He can't keep his attention for long. He always wants to run around, play, and then he's also very hyperactive. So usually you might think, don't all children do that? But trust me, if you've met an ADHD child, it's completely normal. I've had one who came to my office once, just completely made a mess of everything. Just entirely scattered my table and jumping everywhere and like that. So it's a psychosocial problem. Quite burdensome. As a parent, you might even need, maybe almost 2 nannies to be able to keep that child, in check. Because they're very hyperactive, they're very impulsive, and they can't keep their attention for long. And so it's a rather burdensome problem for parents.
Wow. Well, is this an age-based ailment?
Yeah, before you make a diagnosis of ADHD, the child must be 7 years of age. You make the diagnosis before 7 years, rather. So anything like that, they might just think it's truancy or something else. But usually by the age of 7 years, you should have made that diagnosis and said, okay, this child has ADHD. Outside that, then there might be some other issue, maybe psychological, that is affecting the child. So yeah, based on age, we have a cutoff of 7 years to be able to make that diagnosis.
All right. Is this present in adults, or do children often outgrow it?
So, like I said, because we have an age range of 7 years, it's present in adults, but it's because they grew into it. Outgrowing, yeah, everything can be outgrown, but not like the child just stops having it all of a sudden. With medical treatment, with psychotherapy, behavioral therapy, and things like that, you can help slow it down, or maybe make sure that it's gone before they get into adulthood. So yeah, adults can have it. It's something that can progress into adulthood.
All right. Well, it's believed that there are 3 types of ADHD. We have the predominantly inattentive, predominantly hyperactive or impulsive, and there is the combined. That's the one where the child has all the 2. So talk to us about the symptoms of each of them.
Yeah, so to make a diagnosis of ADHD, you need that impulsivity, you need the inattention, and then you need the hyperactivity. Those 3 kiddos must be met. Inattention is that you tell the child to sit down here, or maybe in class, the child can't just sit quiet. He has to just move. Impulsivity is that he doesn't think before doing anything. He just jumps at any opportunity. He sees, for example, your phone or something, he just jumps at it. And hyperactivity is that he can't stay calm. These kids really don't get a lot of sleep. And so based on that, it can be classified as those that are, more of the impulsive, more of the impulsive and hyperactive, and then those that are, have more of the attention deficit, and those that are combined. I think it's just basically for a better understanding, especially amongst doctors. So I can tell you that, okay, this child has more of an attention deficit. It's just basically for classification. I don't think it really alters the medical management so much, except maybe for the psychotherapy. It's just for us to understand, what the child is going through. Obviously, if it's mixed, then you have a lot more work to do. So it's for us to have an idea of the domains that, the child, the illness, occupies in a particular child.
All right. Now, from what you have just said, and of course from what is generally obtainable, most healthy children are probably inattentive, hyperactive, or impulsive at one time or another. And the same is true of hyperactivity. Young children are naturally energetic, they often are still full of energy long after they've worn their parents out. In addition, some children just naturally have a higher activity level than others do. So with this in mind, when should children be classified as actually having ADHD? Because when you were talking about hyperactivity, I was just thinking about my son, and I felt like to a very large extent, I mean, there are times he can be very active and I can be so tired, but he's not worn out yet. So at what point really can we start saying that, okay, this is actually ADHD and not just the normal phenomenon with children?
Okay, that's a good question. So we have a rule, making a diagnosis of ADHD, and the rule is that must be present in two domains. So it must be present either at school and then at home. Child, when you take him outside, he will probably take some time to acclimatize to the environment before he starts becoming hyperactive. So if a child is hyperactive at home and is okay at school, we won't say he has ADHD.
Okay.
At school and is quiet at home, we won't say he has ADHD. So that rule must be maintained, that it must be in two particular domains before you say the child has the ADHD. And then, there's the checklist. Before you make that diagnosis, we have a particular checklist. There are so many kind of questionnaires, what we call them, professional questionnaires, not just average questionnaires, that have been created from various studies. So there are certain questions that we ask and tick, and if the child the criteria, gets to a particular score, then we can say this child ADHD. So probably ask questions like, okay, when you tell him to sit down, how long can he sit down? How long does he run around? How often does he do it? And so it's a very lengthy questionnaire. There are about 4 of them. I can't fully remember their names now, but they've been created professionally, by people who study this illness. And they say, okay, if this child has a particular score of this, they can actually authorize.
All right. Let's turn our attention to the causes and risk factors of ADHD, because I feel that it's very important we understand if there are causes or there are risk factors. At least it will better prepare parents to manage this particular condition. Doctor, if you can hear me, please go on ahead.
Well, like all psychosocial illnesses, like autism, ADHD, things like that, there is no one known and any cause whatsoever. Is most likely genetic. Genetic in the sense that the child is born that way. Many times I have to counsel these parents and I tell them, look, it's not your fault. It's not like, okay, maybe because you didn't breastfeed for 6 months and that's why the child came down with this. It's something genetic. You couldn't have altered it. You can't alter your child's genes. Statistically, it's been shown that, if parents had any signs of ADHD or suffer from ADHD, the child too will likely come down with that. So that is genetic. And some of the people I haven't been quantified, but once you have a genetic illness, then your job is to prevent its progression and maybe at most its manifestation or full manifestation. Well, risk for it coming out, there is no known risk factor for it, manifesting. But obviously, when you have a genetic illness, what you want to do is stop it from progressing further. And so, if you have a child who is already showing signs of ADHD, the first point of call will be to start some kind of treatment for the child, and psychotherapy. Parents can also initiate their own psychotherapy, although there are psychologists who do this or therapists who do this. But, working with the child, talking to the child, all those little things help out, screaming. I've had, like I said, I have patients, the parents left the child with the grandmother, and the grandmother doesn't even scream anymore because she has screamed so much and she's tired. So it's just to give an idea that screaming doesn't really work with these children. They, to a huge extent, don't know what they are doing. It's like they are trance. They are just, it's just the manifestation of the illness. So it's first of all to be patient with them, start, talking to them, start trying to calm them down. Maybe reduce their movie intake. When they start watching things that get them so excited, it could get worse. So I think, and then obviously presenting to the hospital, and so that we start out medical treatment. That's the best that any parent can do to prevent it from progressing, not coming out or starting out.
All right. Before we talk about management and treatment, I'd like you to talk to us. Are there likely complications from this ailment?
Yeah, trauma. That's the child could get hurt, with all the jumping around and stuff. The child could get physically hurt. And then obviously, very poor school performance. They can't sit down to listen to their teacher. Many times they have to fail classes. Sometimes they have special schools if it's a very severe type, because it's also graded into mild and severe. So if it's a very severe type, maybe they can't even properly attend school. So you have trauma, you have poor school performance, and then just generally the low self. They keep up with friends. They can't have too many friends because none of their friends want to be around somebody who is always active, playful. It's not fun. So those are the major concerns that we have. The psychological impact of this, and then the educational impact
And of course,
of
how
this
it's
illness.
okay. I was going to say, and of course, how it probably makes the parents or the caregivers feel.
Yeah. I mean, the parents are like I told you, the case I managed lately. The parents, we are living in Dubai. They brought the child back to Nigeria, and it was the grandmom that was doing all the taking care of, and even the grandmom was tired. So the parents are usually very fatigued. They are tired. They it's very difficult for them. So many times, as pediatricians, we have to also counsel the parents, a lot, because if the parents get tired and they don't do their job, then that child could get a lot.
Yeah, I really feel for them. I hope you've been able to help them get the needed care, because I mean that child needs to be managed. That child needs to be taken care of. They can't keep tossing the baby from grandmother to any other person, really. I hope the child gets well, the necessary care. Now, very quickly, let's talk about managing and treating ADHD. I guess you already put us on that path with this particular story you shared.
Okay, if I want to go step by step, first of all, you introduce on the caregivers. This is what is wrong with your child. Your child just a normal, not just a, it's not just somebody who is just disrespectful like that. I think that there was another case I had, and when the child came into my office, I had to, the mother hadn't told me anything. And by the time the child started, messing up my table and stuff, I made my diagnosis even before the mother told me anything. So the first step is to, or the caregiver, know that this is what's going on with your child. I think that plays a very huge role, for them to understand that it's an illness. If you don't have a stubborn child, you have a child who's going through it, and he would have wanted to be better, but, this illness is what is making him behave this way. Then the next step is there are some medications that we use, psychostimulants. It's funny because the inattention is called depressed neurotransmitters. So for you to be attentive, you need a certain amount of neurotransmitters like dopamine to be active in your brain. But because they don't have enough of that, they are very inattentive, and then they can now get hyperactive. So we give them drugs like methylphenidate. That actually is a psychoactive medication. It doesn't actually suppress them. It actually increases the level of those neurotransmitters in their brain, so that they can now pay more attention and stay calm, to carry their normal activities. So for me, before they leave my office on their first visit, I must prescribe that medication. Then subsequently, their therapies, we help the child, cognitive therapy, behavioral therapy. I have to confess, I'm not a therapist, but I know that they do a lot of talking, talking to people. The content of their speech, I can't fully tell you, but I know that, they try to, engage the child in certain exercises, certain activities that will help the child remain calm and more focused on stuff. And really good success, especially if it's mild and moderate. That, and then also the parents are also taught some of these things, because they can't always bring the child to the hospital. So the parents and both the teachers as well are given some of these behavioral therapy techniques that they can apply to the child and help the child get better. And for the most part, that's what can be. There's no such kind of option or some magic medication that's just going to make it disappear. It's a gradual process. It's something that will take time, but hopefully, some of them get a lot better afterwards.
All right, thank you so much, Doctor. You've done a great work, really taking us through ADHD, how it's being managed, and a lot of the things we really need to know about it. And thanks for sharing your experience with some of your patients with us.
Thank you very much. You're welcome.
All right. Well, we've been speaking with Dr. Ikechukwu Okongu, consultant pediatrician with University of Nigeria Teaching Hospital, Enugu. I guess you had a great time, just like I did. Many thanks for watching. My name is Perpetua Fasami Peter. Bye for now. Do enjoy the rest of the day.